Hello, my name is Jason Clark. I'm with the Pulmonary and Critical Care Medicine Department, and we're going to talk today about e-cigarettes and vaping. Uh, Talk sort of has divided loosely into four parts. First, we're going to talk about the just kind of the details and description of how these devices work and how much they're being used. Then we're going to go into the toxicity, especially when comparing them to conventional combustion cigarettes. And then we're going to talk about their use as smoking cessation aids and whether that's practical or not. And finally, we'll end with some conclusions about them and what to talk to patients about with regards to these. So first of all, let's go through the anatomy of an electronic cigarette. They were first introduced in China in 2004, and they hit the U.S. market in 2007. And it's a overall pretty simple device consisting of a rechargeable battery, a heating coil with an attached wick, and then a cartridge or chamber for liquid to be vaporized and then inhaled. They've actually changed quite a bit since 2007. There's considerable variation from early generations to the current models. Here's a picture of a representative early generation model. And as you can see from the picture, it sort of looks a lot like traditional cigarettes. Even the charging case looks like a cigarette pack, and the devices themselves are the size and shape of a traditional cigarette. They're sort of purchased preloaded with cartridges. Some of them were disposable or they can be rechargeable. Really, you can sort of see that this device would appeal to current smokers and was kind of originally marketed as a smoking cessation device or an alternative to traditional smoking. More current generation devices look something like this, and the difference is quite a bit. They have a large tank for the user to fill with the liquid of their choice rather than necessarily having preloaded cartridges. Multiple tanks can be purchased so you can rapidly change flavors or nicotine doses sort of on the fly. There's variable voltage settings, so affecting the type of vapor, as people will call it, the throat hit. Basically, you want it to sometimes you want to feel it burn a little bit more like a traditional cigarette, and you can turn up the voltage settings to do so. The flavors can be used in isolation or they can be mixed, and so this sort of device encourages a lot more experimentation. And as you can see, it has sort of minimal to no resemblance to traditional smoking, which may make it appeal more to never smokers. As far as the liquid that's put in it, this is, with regards to nicotine e-cigarettes, the e-liquid or e-juice or vape juice, it consists mainly of four things: propylene glycol and vegetable glycerin, which are in various ratios. Then there's some sort of flavoring and nicotine, and the nicotine can be in stepped doses, ranging from roughly 2 to 16. But it's hard to really pay a lot of attention to the dosing ratios, as I found that there's a lot of variability when you go to a particular smoke shop and you're not really sure what you're ever getting for sure. The first two components, the propylene glycol and the vegetable glycerin, were initially considered safe as food additives, and that's how they sort of got approval to be in these, although the effect on inhaling them once vaporized into the respiratory tract is a little bit more unproven. There is innumerable different flavorings in use, and it's difficult to account for the safety of all these substances when inhaled, especially when people mix and match various ones. And as I mentioned at the beginning, the nicotine dosage is not rigorously controlled and can vary widely. Let's talk a little bit about prevalence. Most of the studies are going to be based on surveys and self-reporting. 1.8% of U.S. adults had tried it in 2010, and that had increased to 13% in 2013. 20% of users were non-smokers when they started. A lot of focus in the literature is on the prevalence in adolescents. The CDC estimates that the adolescent use doubled over the course of 2011 2012, eventually got up to 1.78 million, increased to 16% of adolescents in 2015, raised a lot of concern over marketing and sales practices for various reasons. Obviously, e-cigarette use could lead to traditional cigarette use, as well as nicotine itself, has been shown to have significant negative side effects on the developing brain of an adolescent. So they are considered an at-risk group, and that has led to a lot of scientific interest in publications, and eventually has led to a significant congressional action. Here is a study from JAMA talking about the association of e-cigarette use with subsequent use of traditional cigarettes. It was a cohort of students in Southern California followed longitudinally. The hypothesis was being that e-cigarette use may lead to traditional smoking, and they noted that there was 30% use of cigarettes at a 6-month follow-up versus 8% smokers in non-e-cigarette users. Now, this is just an observational study. You can't establish causality, and it's a limited population. The follow-up study showed that increased nicotine doses correlated with higher rates of subsequent smoking, meaning the increase in nicotine doses in the e-cigarette use perhaps led to more dangerous addiction. Here is a JAMA study talking about the association between initial e-cigarette use and subsequent smoking. This is more of a meta-analysis of several studies, 9, including 17,000 people, and prior e-cigarette use was associated with 23% chance of smoking versus only a 7% chance in non-users. Again, it's only observational data. It may be that e-cigarette use sort of selects for risk takers rather than being a causative agent, but it certainly was a big cause for concern. As I'm sure many of you know, multiple manufacturers were at the time really marketing a lot to adolescent users, especially with their choices of flavors and packaging and product placement. And there's been a lot of regulations to try to curb that after some of this data was put forward. Let's talk about the toxicity of these devices. Unfortunately, you know, since we've only been having them around over the last 10 to 15 years, it's hard to say what the long-term toxicity will be given the short lifespan. The data mostly centers a lot around just sort of chemical analysis of e-liquid and the aerosol produced and comparing that with traditional cigarette fumes. On top of that, there's been a lot of data documenting case studies of people with particular pulmonary toxicities. Here's a representative chart. This is a sort of a collection of multiple studies summarized and basically picking out a few substances known to be carcinogens that are found in significant quantities in regular cigarette smoke, which is the column on the left, and then the same chemicals found in electronic cigarette vapor on the right. And on the very far right is the ratio from conventional cigarettes to electronic cigarettes. And the whole point of this chart is basically showing that these substances are still present in electronic cigarettes, but are certainly present to a far, far lesser degree. Whether that is significant as far as long-term outcomes is hard to say, but at least is somewhat encouraging. Also of note is there are many, many more unique chemicals found in conventional cigarettes. Once you combust something, there is over 7,000 different unique compounds in cigarette smoke, many of which can be toxic. And the amount of unique chemicals generated in an e-cigarette vapor is much smaller than that. All of this sort of leads to the conclusion that it's likely there's higher safety in electronic cigarettes, but they're also not completely benign. Payton et al. Did a report on formaldehyde hemiacetal, which is a formaldehyde releasing agent. The point of this study really showed that it can exceed the concentration of cigarette smoke, but only at high voltages. And as I mentioned earlier, some of the newer devices have a variable dial where you can adjust how much voltage you use. They didn't detect any at all at 3.3 voltages or less. Whether this has any major effects on long-term outcomes is unknown, but it does increase formaldehyde, which is a known carcinogen. And the theory being that if you're going to use electronic cigarettes, using them at lower voltages may be safer. And there's been some other reports echoing that as well. Here's a a study comparing the nicotine and basically looking at biomarkers of known toxic substances in nicotine cigarette users versus e-cigarette users. They actually looked at urine markers in over 5,000 people, and they were grouped as smokers, non-smokers, and e-cigarette users and dual users. And they actually tested 50 different metabolites. The chart on the next slide only has sort of 9 representative compounds, and they sort of quantified the levels for each subgroup. Here's the 9 that they listed, at least in the article, including nicotine and heavy metals, as well as some volatile organic compounds. What they found was that the majority of this, as you would expect from the earlier data that I showed, the majority of the substances were significantly lower in the electronic cigarette group, but still higher than in non-smokers. And they were in the highest concentration in dual users, people that smoke both cigarettes as well as e-cigarettes. Interestingly, 93% of the e-cigarette users in the study were former smokers with a mean quit date of 3.5 years prior. And whether that could affect the data as far as finding biomarkers left over from their long-term cigarette use is hard to say. The combustible cigarette use was similar between the smokers and the dual users, and so it's hard to know whether how much that contributed more to the metabolites found rather than the e-cigarette component of that subgroup. The other thing to note is that the data comes from samples taken during the sales of early generation devices, and the newer devices are significantly more efficient at nicotine delivery. It is possible metabolites would be higher in the newer devices. As far as pulmonary function, the long-term effects are not really known. There's no real acute change in spirometry when you are exposed to vape aerosol, in contrast to changes that you can see with cigarette smoke exposure. It's unclear what the clinical relevance of this is. This is in contrast also to some people that have had actual pulmonary toxicities from e-cigarette use. Their spirometry numbers can certainly linger and be abnormal for quite some time. I did come across one study on wound healing. It's an animal model study. They used Sprague Dawley rats to look at surgical flap necrosis. They exposed the rats to placebo versus vape versus smoke in a closed chamber for 30 minutes twice a day for 30 days. And then they raised surgical skin flaps in all the rats and measured the subsequent necrosis. And the percentage of necrosis was similar between the two exposed groups and higher than the controls. And it would just argue that if you were going to have a surgical procedure, especially a plastics procedure, you would probably do well to cease vaping, as just like they recommend for traditional smoking prior to and after the procedure. Let's talk a little bit about other toxicities besides the known carcinogens that are in cigarette smoke and maybe in lesser degree in vape liquid. There has also been some novel toxicities seen sort of in a sporadic fashion. You will find most of these, as isolated case studies here and there, but they do represent, a growing number, and it's hard to account for where this will all go in the coming decades. Some of these listed here, there's lipoid pneumonia, hypersensitivity pneumonitis, ARDS, acute eosinophilic pneumonia, and E-Valley, which we'll get to in a little bit because it certainly got the biggest headlines in 2019. A little bit of word about lipoid pneumonia. It's interesting that it's been found in a number of cases. It's really more of a historical diagnosis, not something we see a lot of anymore. It's usually in the past been associated with petroleum-based products or oil-based laxatives that would get aspirated into the lung. There's some interesting occupational exposures like fire eaters, but it's otherwise not something that one sees very often. It's a lipid deposition into the lungs, and it overwhelms the clearance mechanisms. And it can present as infiltrates or even as a single mass, sometimes leading to an unnecessary resection. Sometimes they're asymptomatic, and you just find them on radiographs, but certainly significant cases can lead to severe dyspnea and hypoxemia. I have one case report of a 34-year-old female, 3 months of dyspnea after using an electronic cigarette for 3 years, and she had bilateral infiltrates, restrictive spirometry, and reduced DLCO. Definitive diagnosis was made on surgical biopsy, and no alternative exposures were identified. Here's sort of her bilateral, sort of even infiltrates, and here's ground glass opacities sort of diffusely on her CT scan. She was treated with steroids for 18 months and advised to stop vaping. Both her symptoms and spirometry improved, but her DLCO did not. The authors were not fully convinced that she was compliant with cessation, and they attributed the toxicity to the inhalation of the vegetable glycerin in the vape juice. There's been several other similar case studies of lipoid pneumonia reported. This was before the EVALI epidemic. This case report was an ARDS and an 18-year-old female presented with acute pleuritic pain and dyspnea, rapidly progressed to ARDS needing mechanical ventilation. She had typical imaging with bilateral infiltrates and pleural effusions, and she had just started using electronic cigarettes 2 to 3 weeks prior, and no alternative exposures were noted. They attributed this to acute hypersensitivity pneumonitis with progression to ARDS, and she was also started on systemic steroids with good clinical recovery. And then let's talk about EVALI, or e-cigarette and vaping-associated lung injury. A lot of different presentations, from mild respiratory symptoms to severe respiratory failure. Fever and myalgias are frequently associated. CT and chest X-ray findings are nonspecific, but patchy ground glass infiltrates are typical, at least initially, and it can progress to severe ARDS. Systemic steroids may be helpful in severe cases, and it seems that most patients are receiving steroids at this point if they if this is a suspected diagnosis. As of the last study I saw, the epidemic consisted of 2,558 cases and 60 deaths. This was mostly during the year of 2019. Significant interest in this sort of waned during 2020 due to the COVID epidemic, although there are some reports of it coexisting with a COVID diagnosis. Most of the studies have shown about an 80% association with THC vaping rather than just nicotine e-cigarettes. And it's really hard, I think, to get that number accurate. You know, there's going to be reporting bias and legal ramifications in a lot of states regarding that. Also, a lot of people use both, and so trying to ferret out which one is the toxic source is very difficult. Eventually, they implicated vitamin E acetate as the main causative agent, which was found on bronchoscopy specimens. It's an additive used to thin THC oil, and possibly one of many additives that will eventually be found to cause toxicity. But once the vitamin E acetate was found and removed from circulation, the cases dropped off quite a bit. Interestingly, this was a United States epidemic. It was not seen in Europe, where e-cigarette and vape use is also very common. Another toxicity to consider is oral ingestion. You know, e-liquid containers are not childproof, and the labels, you know, they are colorful and may say things on them like cotton candy. They sometimes have a sweet taste or smell. But a single bottle can contain a lethal dose of nicotine, especially for a small child. And this is certainly in contrast to traditional cigarettes, for which no child is trying to eat a bunch of cigarettes, but drinking a liquid that looks like might be sweet is certainly a plausible. Symptoms include nausea, vomiting, labored breathing, ataxia, tachycardia, and it can progress to neuromuscular blockade and respiratory failure and death. And there has been a noted increase in calls of to poison centers for nicotine toxicity related to this. Certainly label regulation and a better informed public and childproof containers could help with this issue. All right, so summarizing all of that about toxicity, there are known carcinogens present, but in much lower amounts than compared to traditional cigarettes. Components and dosages are not always reliable, and higher voltages may increase toxicity. There's potential harm from flavorings that's difficult to account for, and novel toxicities being reported, including parenchymal lung disease as well as poisoning from oral ingestion have been seen. Despite that, it still is a potential positive agent for smoking cessation for several reasons. One is that it really closely mimics the habit of smoking. Many people addicted to cigarettes, in addition to being addicted to the nicotine itself, are addicted to the ritual. And e-cigarettes most closely mimic that compared to other nicotine replacement therapies. You can also use them and progressively decrease the nicotine dosing over time. And there has been some promising data, although it's has not been overwhelming. Here was an initial trial in 2013 in The Lancet. 657 people expressing a desire to quit smoking. They were randomized to e-cigarettes, nicotine patches, and placebo, which was e-cigarettes without nicotine. The primary endpoint was abstinence at 6 months, and there was a higher rate of abstinence in the e-cigarette group, but only 7.7 to 5%, and it was not statistically significant. There was a significant difference at 1 month, but it was lost by 6 months. The limitations of the study was that it was powered for an assumed abstinence rate of 20%, which was not achieved in any group, and it had a high dropout rate in the nicotine patch group. The authors thought that many of the study volunteers signed up to because they were just interested in e-cigarettes and were disappointed in their randomization. Based on the data of the study, only early generation devices were available at that time, and there's no standard protocol for cessation, at least during this study, with electronic cigarettes versus patches, which have been used for a considerable amount of time. Other studies have noted at least a reduction in smoking after initiation of e-cigarettes, but these are observational and rely on self-reporting surveys. In the New England Journal in 2019, there was another cessation trial of 800, almost 900 patients motivated to quit, randomized to e-cigarettes versus nicotine replacement products of their choosing. And the primary endpoint was abstinence at 1 year, as measured by carbon monoxide levels. 18% in the e-cigarette group versus 9% for nicotine replacement had successful abstinence. They notably used weekly behavioral therapy in both groups, and this study utilized newer generation vape devices. There has since been a larger meta-analysis looking at all the different smoking cessation studies, and it does tend to show that there is a favorable benefit to e-cigarettes as far as abstinence, but it's not large. It's 2 to 3%, statistically significant, but given the different toxicities or potential for unknown toxicities, it's a little harder to say whether that's that difference alone is worth recommending. Which gets to kind of a larger sort of almost philosophical discussion regarding use of these in smoking cessation, which people in the literature talk about harm reduction versus renormalization. And people that favor the harm reduction side of things say that we should be using this to help curb cigarette smoking. It affords less toxicity. It decreases the overall medical burden of smoking. If widely adopted, it could lead to hopefully the elimination of traditional smoking, and that banning or restricting e-cigarettes could remove a valuable tool in the overall war against smoking, and that focusing on the minimal toxicity is alarmist. People on the sort of the other side of the aisle, note that the decline in smoking is directly related to its restriction in public places and its overall inconvenience. Whereas if you vape, it's much more accepted to do anywhere. It doesn't generate a smell, it doesn't generate lasting smoke, and so it's easier to do in more places. It's also less commonly encountered, so their thought is that if vaping is embraced, this element could disappear and could lead to increased overall nicotine use, especially as non-smokers are initiated. And as I mentioned on an earlier slide, there was that data that 20% of e-cigarette people were former never smokers. So overall is going to lead to an increase in total nicotine addiction, which may in turn lead to increased smoking as well. There's also a considerable mistrust by the medical community of major tobacco companies based on past practices, including filtered cigarettes marketed as safe and extensive marketing to youth, as well as heavy current investment by the major tobacco companies in the e-cigarette movement. And I think that as far as advice to clinicians and advice to patients, it's hard to be definitive either way on this issue. I think both sides have some fair points, and really the lack of long-term data is what keeps this nebulous. I will say that e-cigarettes appear to be safer than traditional smoking, but they are not entirely benign. They remain addictive when containing nicotine, and certainly can lead to progression in smoking or dual use. They may be an effective tool in cessation, and certainly some studies have shown that. Marketing to youth as well as public perception of safety could lead to an overall increase of nicotine addiction, which is certainly a considerable worry. I think the best use of them as far as patient care is to discuss with the patients the potential toxicities of these devices and perhaps consider them as an option in patients that have otherwise failed other traditional methods of quitting smoking, and but yet are still motivated to try something. Novel toxicities in the U.S. And the U.S. Valley epidemic need further studies before really true definitive recommendations can be made. And I have a couple of slides of references here. And that is all. Thank you for listening to my talk.